Hello everybody and welcome to another edition of Physiology Made Easy with me, Dr. Amir Sandhu. Now in today's episode we're going to look at exercise prescription for patients with multiple sclerosis, and the information is going to be particularly relevant to patients who have MS and also healthcare practitioners that are involved in their care. Now what I would expect for you to get out of this presentation is to understand the basic or underlying pathophysiology of multiple sclerosis, and then use that kind of knowledge to understand how exercise programs may be beneficial to this population, and certainly to develop confidence in developing exercise programs using the scientific knowledge, using the scientific literature. I'd also want you to take away from the fact that there are some important considerations when you program exercise for patients with MS, and this information is going to be useful for any patient that wishes to take part in a program. So some things that you need to think about that perhaps you wouldn't if you were working with the general population. And also in the second part of this video series, we're going to get the patient's perspective of living with MS. So I will interview a patient who's lived with MS for quite a number of years, and she will share her insights and experience about the condition as well as the importance of exercise. Now, before we get into the pathophysiology of MS, we need to understand the basic kind of physiology or anatomy of the neuron. So we have billions of neurons located in our body, and they form part of they consist of the central nervous system, which is the brain and the spinal cord, and we also have the peripheral nervous system, which consists of all of the neurons that travel to the different tissues in the body. Now, one neuron might look like this. So it will have a cell body, it will have a nucleus, and it will have these dendrites, like these tentacles which synapse with other neurons, and they communicate electrical signals. Now those electrical signals are known as action potentials, and whilst it's beyond the scope of today's video to cover action potentials, I have linked in the description to another very good overview of what action potentials are. But essentially there is electrical activity, ionic movement across the axon, which is the part that transmits that impulse to a target tissue or to another neuron, and that axon is coated by this sheath. We call it the myelin sheath, consisting of Schwann cells. Okay, so it's a lipid layer, it's a kind of a fatty layer, and it also has these nodes of Ranvier, which are basically gaps that allow the signal to jump from one gap to another. We call that saltatory propagation. It speeds up the electrical impulse, so you have very quick communication between neurons. Okay, so that is essentially the structure of a typical neuron. These axon terminals will branch with other neurons or to target tissues to elicit a response, to get that communication. Now, multiple sclerosis is a neurodegenerative disease, so by that we mean that there will be some aspect of the neurons that become damaged through some physiological or pathophysiological factor. It primarily targets the brain and the spinal cord, so it's the central nervous system that is affected. In terms of its development, females are more likely or twice as likely to develop it compared to males, and it does tend to present in individuals that are between 20 to 40 years old, so it's not necessarily a condition which is exclusive to older people. The prevalence in the United Kingdom is unknown, but what we do know is that there is a prevalence of about 2.5 million individuals worldwide, so it is a major clinical condition, chronic condition that causes considerable disability. So if you are involved in rehabilitation, then it's very important to know about multiple sclerosis. Now, essentially what happens is, we saw a healthy neuron on the previous slide, but in MS, we basically have damage to the myelin sheath, and that damage is mediated by autoreactive immune cells, and one of the main ones in MS is T cells. So T cells cause inflammation, which specifically damages the actual myelin sheath, and that will affect the conduction of that electrical signal, and will obviously then affect the function of whichever neuron or nerves that tissue was affecting. Now, one of the key things is that when you have a loss in a myelin sheath, we call that demyelination. You may also get scarring as well of the axon, of the other structures of the neuron, and eventually with time, as the disease progresses, you may have axon loss, and the neuron may completely die, in which case certain functions of the body will cease. Now let's have a look at that in a little bit more detail. So the pathophysiology of multiple sclerosis can be summarized by the things that are happening in this slide. It's very complex, the pathophysiology of multiple sclerosis. There's a number of things that are happening. Now, generally what happens is that there will be some factor in the environment that might trigger an autoimmune response in the body, and there may be individuals that have genetic susceptibility to multiple sclerosis, so that environmental trigger might switch on or activate that gene and then start expressing this kind of autoimmune response. But essentially what you're having is a formation of lesions or plaques within the neurons, okay, within the axon, and they will happen in the neurons of the brain and the spinal cord, and essentially what is happening is there are a number of phases of what is a very complex series of reactions. So the initial phase is going to involve activation of inflammatory cells, okay? Now what I'm actually going to do is just zoom in to this diagram here so that you can see this at home more clearly. So what we can see here is inflammatory cells. We've got B lymphocytes, T lymphocytes, and microglial cells. All of these are activated, or they become activated by some triggering factor. When they become activated, they actually cause, first of all, they'll cause inflammation, but they'll also cause oxidative stress. Oxidative stress, by its very nature, scavenges electrons from other tissues. And in this case, what it does is it damages the myelin sheath. So remember the fatty sheath that allows the propagation of the electrical signal, that becomes damaged by oxidative stress. And it also damages oligodendrocytes. Now, oligodendrocytes are extremely important cells because they are responsible for producing new myelin sheath. So they're responsible for the repair and regeneration of myelin. So if you have oxidative stress in the oligodendrocyte, then obviously you're going to have there's a greater risk of any myelin damage not being able to be repaired. Okay, so that's what happens in that kind of initial phase. Now if I zoom back out again, what we can see is that in multiple sclerosis is characterized by different phases, and one of the most earliest phases is the relapsing remitting phase. Now this is a phase that's common in about 85% of patients, and it involves periods where there's inflammation and certain functions of the body are affected, but there's also remission, so the condition gets better. Therefore, this damage to the oligodendrocytes and to the myelin is reversible. Okay, it can get better, the oligodendrocytes can recover and regenerate more myelin. Okay, so that damage can recover. However, there is a progressive phase which occurs over a period of 10 years. It might occur sooner in some patients, and that actually causes atrophy, so a reduction in the size of grey and white matter in the brain. And essentially what's happening in that situation is you're getting this kind of perpetual low-grade inflammation. So let's zoom back in again to the diagram. Now, what we can see is that once you have oxidative injury, you also start to have damage to the mitochondria, which are contained within the cell body. Now, that mitochondrial dysfunction is going to cause a whole range of other inflammatory molecules to be released, and also other free radicals to be released within the neuron. And eventually, that's going to cause, over a long period of time, hopefully you can just about see it on the presentation, chronic axonal demyelination. So you're going to have this long-term low-grade inflammation causing long-term damage to some of the specific processes. Now, the cells that are involved in this process will involve pro-inflammatory cytokines, which are very potent in causing inflammation within the neuron, within the axon. They'll start to activate other cells like proteases, lipases, nitric oxide synthase, and they will further increase inflammation. So it's like a vicious cycle that continues, and all the while you're having an increase in oxidative stress continuing to form. So over time you get this degeneration to the axon. So if we zoom back out again, we get degeneration to the axon, to the myelin. The oligodendrocytes are kind of irreversibly damaged, so they can no longer reproduce new myelin. And the neuron dies, okay? So the neuron dies, and what will happen then is that part of the brain or the spinal cord will shrink. it will just become non-functional. And this is what we refer to as the primary and the secondary phase of multiple sclerosis. Now, it's very important, I have alluded to this, but it's very important to mention that these inflammatory cytokines, reactive oxygen species, and nitric oxide, they are released from the B lymphocytes, the T lymphocytes, and the microglial cells. Okay, so those cells, they initiate that initial response, but they also involve later on. It's a very complex process. I have provided a reference in the description if you wanted to know more about the pathophysiological mechanisms of this condition. So the clinical course of MS, so the initial presentation is this relapsing remitting phase. The damage to the myelin occurs, but it's also repaired when you're in that remission phase, and then you have restoration of central nervous system function. Okay, that's good. So the symptoms of relapsing remitting, these are some of the symptoms. There will be different symptoms in different patients, so it's not the same thing that's going to happen in every patient. But one of the things that will happen due to these disturbances in neuronal activity is issues with cognition. Okay, so cognitive deficits, understanding, processing information. There'll be visual disturbances. There may be double vision and other visual problems. One of the major symptoms of MS is severe fatigue. And this is a fatigue that, unless you suffer from MS, you probably cannot experience or understand what that fatigue is actually like. So severe fatigue, there's weakness or muscle weakness as well. There's also balance and coordination issues with ataxia. So that will increase the risk of other injuries with falls, etc. There's also evidence to show that some of the symptoms include mood changes, anxiety, depression in particular as well. And then there may also be issues with bladder function and the movement of bowel movements, etc. And there's numbness, tingling, heaviness. Those are some of the symptoms that you might experience. You might feel some tightness around the chest. You might feel difficulty swallowing. There's a whole host of symptoms that a patient might experience. Now, over a period of time, so over, say, for example, 10 years, there may be the secondary progressive phase of MS, and the secondary progressive phase results in some sustained and irreversible damage. So that inflammatory process, that oxidative stress that we were talking about, continues and involves neuronal death. And that will basically mean that you will have this period of relapse and remission at the beginning, but over time you'll have less remission and it will just be worsening disease. It will just gradually get worse and it will start to affect more and more functions and therefore the quality of life. Now, by far, primary progressive phase is the worst. Thankfully, it only occurs in 10% of cases, but if you're a patient that has primary progressive phase, it can be very worrying, and it can really affect you and your loved ones in a number of ways. The problem with progressive phase is that you don't really have any remission. You just, from the onset, you get worse and worse. So it's very important for the neurologist and for healthcare practitioners involved in the care of MS patients to initiate some evidence-based interventions as early as possible to try and prevent some of the declines that will come from this condition. Now, the diagnosis of MS is usually made using an MRI scan. So the MRI scan will look for any kind of formation of plaques or lesions within the neurons of the brain and the spinal cord. And what they actually do with an MRI scan is actually infuse or give a contrast-enhancing agent called gadolinium. Okay, the gadolinium will actually go into the neurons and highlight any areas where there is a lesion as bright white patches. Okay, so we can see some lesions occurring in this MRI scan here. So in the brain and the spinal cord, the gadolinium will kind of enhance or show that kind of contrast, white patches where you've got active lesions. The good thing with MRI scanning is that it doesn't show old plaques, so any plaques that are older than 3 months may not show, so it only shows active lesions. An MRI scan might also show black patches as well. Now, black patches represent neurons which have died, they've ceased to function, and you'll see kind of like a black patch within the MRI scan. Okay, so gadolinium is the contrast agent used along with an MRI scan. The criteria that is used to actually determine whether MS is MS and not a stroke or migraine. So to distinguish it from other conditions, you would actually use the McDonald criteria, which was introduced in 2001 and has been updated or revised a few times since. And it basically shows whether the lesions occurred on different dates, which is known as dissemination in time, and whether it occurred in different parts of the brain or the spinal cord, and that's known as dissemination in space. Now, if those two things occur, then it's very likely that the patient's suffering from MS. Okay, so that's something just to keep in mind. And there is some information about the McDonald criteria in this reference here. So physical inactivity is a concern in multiple sclerosis. So the research evidence shows that patients that have MS have greater rates of physical inactivity, sedentariness, compared to people that don't have MS. Also, if you have a patient that was previously active and then they get the diagnosis of MS, there has been some research to show that 38% of those patients stop exercising completely. That might be due to their symptoms, loss of confidence, disability, a whole host of reasons. Those patients that have the greatest neurological disability will have the lowest cardiorespiratory fitness. And again, if we take these points together, particularly those two, you get the diagnosis, you stop exercising, you're going to get a reduction in your muscle strength and your aerobic fitness, flexibility, etc. So from a scientific perspective, these things are common sense and make sense. And also, when you get that deconditioning, that will contribute to walking impairments. So there's a risk that the stopping physical activity may make the MS worse. Okay, so that's something just to keep in mind when you're working with MS patients. Now, in terms of the evidence base then for benefits of exercise in MS, there's a great systematic review published by Latimer Chung, and that looked at 54 studies that have looked at exercise in patients with MS. And what they were able to deduce from the systematic review was that twice weekly moderate exercise increased aerobic capacity and also muscle strength in patients that had mild and moderate disability. Okay, now they also looked at mobility, fatigue, quality of life as well, some other measures, and the evidence about those outcomes was inconsistent. It doesn't mean that those don't improve with exercise training. It's just that the quality of the studies might not have been so good. So the evidence about those was not consistent. But certainly aerobic fitness, strength, the evidence is there that it does improve in MS patients. Similarly with resistance training, again a systematic review from Coghe G, I hope I've pronounced that correctly. Systematic review with 16 studies showed that resistance training unsurprisingly increased muscle strength. Okay, there was poor quality of evidence for functional capacity, activities of daily living, balance and quality. So that doesn't necessarily mean that these things don't improve with resistance training. It just means that the evidence was poor in terms of the quality of the science. So we definitely need to do more research in this area. And this is a very nice resource, Pedersen and Saltin, exercise prescription for 26 different chronic diseases, including MS. And if you read that report, read that paper, you will see that they cite several individual studies that do show improvements from exercise for depression, fatigue, bladder function, coughing force or respiratory muscle force, and activities of daily living as well. So the evidence is there that exercise can be beneficial to patients at all stages of MS. So some things that you need to, as a practitioner and also as a patient, to keep in mind when you're prescribing exercise is that we should always use the FIT principle. Okay, so exercise prescription should be used using the FIT principle, which is frequency, intensity, time and type of exercise. That's what you manipulate to get progression and the adaptations taking place in the body. If you have a patient that has acute flare, then just focus on activities of daily living. Okay, so sit to stand, stair climbing, walking, gripping, carrying, those type of things are more important than the actual exercise program itself. So keep that in mind. when symptoms are severe, it's very important for the patient to have complete rest. Now, in other chronic diseases, like for example rheumatoid arthritis, lupus, we might advise the patient to continue to exercise if they have a flare and just make sure they avoid the joint that's inflamed. But in MS, the fatigue can be so severe that the patient may injure themselves if they are not, fully energetic. So it's very important that if the patient's feeling the fatigue, that you make sure that they rest, and it's not until they're better that you get them back into your session again. So you need to schedule your sessions when there is the least amount of fatigue. Okay. Now the point here is that some patients, when they wake up in the morning, feel the most energetic because they've had a good sleep and they feel quite refreshed. So scheduling an exercise session in the morning will be beneficial for those patients. Conversely, some patients might feel more energetic in the afternoon after they've woken up, had breakfast and some time to get the nutrients from the food. So it's very important to work with your patient population to schedule the sessions when they experience the least amount of fatigue. So aerobic exercise, and again, Latimer Chung has done some fantastic work in this area, and the references here if you wanted to read more information. The recommendation is 2 to 5 days per week. Now, if you had a patient who is severely deconditioned, they're just starting exercise, you'd want to be at the lower end of that recommendation. Similarly with intensity, 40 to 70% of heart rate reserve. Now, heart rate reserve is measured by taking the heart rate max, which you can get from an exercise test or from the Covanonen formula, and minusing or subtracting the resting heart rate. That will give you the heart rate reserve. So again, you're working at the lower intensity for a patient that's severely deconditioned, and you're progressing over a period of weeks up to that higher number. Now, because we know that MS affects neuron activity, it can also affect the nerves that innervate the heart, the sinoatrial, atrioventricular node, and it can affect heart rate. Now, it's very important in that situation, those patients that do have autonomic dysfunction, that you use ratings of perceived exertion, or RPE, to gauge the intensity of the exercise. And again, something like 12 to 15 would be quite would be quite sufficient to get the adaptations. The Borg RPE scale is widely available if you search for it on the internet. Duration, very important because it's different to other chronic conditions. Start with 10 minutes. So start with 10 minutes and then progress to the longer durations of 30 to 60 minutes. Okay. In patients that are severely deconditioned, consider doing intermittent exercise, okay? So that you're doing these short blocks that are interspersed with long rest periods, or you might do something in the morning, then something after lunch, something in the evening. It's very important to keep that as a consideration because you're trying to make sure that the fatigue and some of the other symptoms don't become a limiting factor. Include all types of exercises. MS patients can do everything and anything. We've got an MS patient doing wheelchair basketball here, some Pilates, swimming, shooting, archery. The MS Trust, which you can just see the label here, provides some fantastic resources for patients about the different types of exercises that you can do, and they've got case studies on individual patients that you could follow. Hopefully gives you some inspiration and ideas about how you can exercise with MS. The key thing is to focus on enjoyable activities. Okay, you want to work with the patients, do some good pre-screening to understand what it is that they want to get out of the session, and make sure that they develop a routine, they have this enjoyment, and that they develop this sense of ownership of this exercise. So the motivation comes intrinsically. It's this intrinsic motivation. So if you can develop that, you're running a successful program. Resistance exercise. Again, if you know, resistance training will increase balance, will reduce fatigue, particularly in muscle fatigue, and also increase functional capacity and activities of daily living. The recommendation is to do 2 days. The intensity, again, different to other chronic diseases, you'd focus on one set, 10 to 15 repetitions at 60 to 80% of one repetition max. Focus more on the lower side in new patients, deconditioned patients. You need to have longer rest periods as well when you're exercising, and what I mean here is because you only have one set, so the longer rest period is between exercises. So if you're doing bicep curls, for example, and then you go on to do something with TheraBands, then you want to make sure that there is a bit of recovery time, sufficient recovery time for the patient. Focus on large muscle groups, especially those involved in maintaining posture. Okay, so that will be beneficial for the patient. What you can see in this picture here is some tubing. That tubing is present when doing resistance training because it helps reduce the risk of falls. So any patients that have balance or coordination issues, they can do their resistance exercises by close to this tubing. So you really want to avoid doing free weights. If you can use resistance machines, they also help with coordination and stability, then that will be better for the patient. For resistance exercise, there is also what we call an Omni Scale, okay, and that basically tells you when the patient tells you, because you give them this tool, how difficult or easy the exercise is after a given set. Okay, so it's on a scale of 0 to 10, extremely easy to extremely hard. And if you've got patients that have muscle weakness, and I would even use it in patients that are severely deconditioned, then this is a very good way to gauge intensity and how hard they're feeling, and then you can tweak it, and the idea is to start somewhat easy, and then you progress more to not extremely hard, but somewhere between the mid ranges here, where you're likely to get those adaptations in function. As always, flexibility is extremely important. Try to get the patients into a habit of a range of motion exercises when their muscles are warm. So you can do some dynamic, like arm rotations, for example, and also some static stretching as well. Okay. Now, if you have patients that have muscle spasms, and this is very common in MS patients, then you might need to increase the duration of the stretch until that spasm subsides. So that's something just to keep in mind. Now, here is the special considerations. Again, this is evidence-based on a very nice paper published in 2011 by Reingold et al. The link is in the description. I hope that you can read this, so we'll try and zoom in a little bit as best as we possibly can. Now, what you can see at the top here is some things that you need to think about in your program, okay? So we know that patients will have a risk of, one of the symptoms is cognitive deficits, okay? So it's very important that one of the things to mitigate against that is that you provide clear instructions in your exercise programming. So, in your class, you've got diagrams to show patients what exercises they should be doing and how they should be doing them. If you're recommending home-based exercise, give them a leaflet to take home. So diagrams, regular instructions, provide verbal feedback as well. So the patients do need close supervision. Uncoordination in the upper and the lower extremities, okay? So one of the things that you can do in patients that have poor coordination is to consider using machines that help to coordinate the movement on the patient's behalf. They also mean that the patient doesn't have to balance themselves. The machine will help to support them, increases safety, reduces risk of injury. Spasticity, particularly severe spasticity. So again, if you've got patients that are working on cycloergometers or on arm crankometers, do use the foot straps, use the hand straps, focus on using machines instead of free weights, okay? Now, we know about the fatigue in MS. So a patient with MS, when they walk, they're going to be consuming much more energy than somebody that's than a healthy person that doesn't have MS. So again, as I was saying in the previous slides, you just need to work with the patient to make sure the workload, the intensity, whether that be the heart rate reserve, the RPE, the Omni Scale, is in a range where the patient feels comfortable and is not going to become severely fatigued so that they can't complete the session. Now, patients with MS do have some poor thermoregulation. Their thermoregulation is poorer, so they can generally become overheated. They can become hot. Okay, so it's very important that you have water stations, cooling stations nearby, so that the patients can consume fluids, keep themselves cool. There is also some evidence to show that if you give patients an ice-cold drink or a cold drink before they start exercise, that's going to limit some of the symptoms symptoms of this becoming overheated. Again, practical things like using cooling fans, making sure that the exercise is at a time when perhaps the body temperature is the lowest, such as the morning. Those kind of things are all considerations to think about. Now, keep in mind that there will be variation in symptoms on a day-to-day basis. So you need to make sure that you're closely supervising the patients, you're ready to adjust the exercise program on a as needed basis. We know that there's bowel dysfunction that happens in MS, so there may be incontinence and urgency as well for urinating. So just make sure that there are toilets that are available, that they're clean, they're accessible, and then of course, again, hydration stations, make sure adequate water is available. So sensory loss and balance deficits. So we know that patients are likely to have some issues with balance. So you need to make sure that when you're performing resistance training, aerobic exercise, and also flexibility training, it's in a seated position. Also, as I mentioned before, using that tubing to improve or reduce the risk of any falls and injuries. Fatigue, we've mentioned it, perform resistance training on days that they're not doing endurance training, so don't include both of those measurements. Try to make sure that they're happening on different days. Now, one thing that you will see, if we zoom back out again, what you will see is some patients will have exacerbation of their symptoms. Okay, now in that situation, if the symptoms get worse, it's extremely important that you stop exercising, you get the patient referred back to their neurologist or the referring physician, and you only resume the exercise once they get medical clearance again, symptoms are stable, etc. So those are the most important special considerations for you to think about when programming. I want to just finish off by going through some of the biological mechanisms that have been shown in the scientific studies that about exercise's beneficial effects on MS. Now, some research has shown that there is an increase in brain-derived neurotrophic factor, BDNF, and that can help to improve cognitive function in patients with MS. Now, BDNF actually increases in everybody when we exercise, and in MS, research has actually shown BDNF levels can reduce compared to non-MS patients. So it's very important that we try to restore that in some way, and exercise has been shown to be beneficial in MS patients. There's also increase in proteins that are neuroprotective, such as insulin-like growth factor 1. Now, what that does is it increases neuroplasticity, so this ability of the neurons to regenerate, to grow, to make connections with each other. So that it all comes from insulin growth factor, and again, there's evidence for that in patients with MS. Now, remember at the beginning of the presentation I talked about oxidative stress perpetuating damage to the neuron via a complex series of reactions. Well, if you exercise, you reduce the oxidative stress, so that means that there's less injury occurring to the neuron, and it means that there's a slower progression of the MS. And that's crucial if you want to reduce disability. Related to that, there is also a reduction in inflammation, and remember, MS actually starts with this inflammatory insult to the neuron. So reduction in inflammation, stress hormones, that prevents or slows this demyelination and the loss of the neurons, the atrophy of the white and the grey matter. So in today's presentation, we've covered the importance of exercise programming in patients with MS by relating it to the underlying pathophysiology of MS. We know that it's a progressive disease, but it does have periods of remission. We know that exercise will work, it's beneficial in MS patients, but you've got to be able to adjust exercise prescription for all of the symptoms that MS patients undergo. And fundamentally, exercise will improve several physiological mechanisms that will hopefully prevent MS from progressing rapidly, so it will improve prognosis and MS disease course. So that's everything for today's presentation. I'd like to thank you very much for your time. Please do join me again where we'll go through another chronic condition very soon. Thank you very much.